E invitaríamos al doctor Sanjiv para que nos hiciera favor de presentar su tema. Bienvenido, doctor.
Buenos días. Muchas gracias por la invitación a visitar Ciudad de México otra vez y dar una presentación en esta conferencia. Llegué aquí muy tarde anoche, mi vuelo retrasó más de 3 horas, pero estoy muy contento de estar aquí. He tratado de aprender español un poco tiempo. Mi español, aunque es mejor que antes, pero no es suficientemente buena para dar mi presentación hoy en español. Mi español es suficiente para pedir una cerveza o una margarita, pero para presentación no. Quizás la próxima vez, ¿ok? Hablo hoy con ustedes en inglés. So thank you very much for the invitation again. You heard a lot about immunotherapy this morning already, and I am going to give you a summary of what I think is going on in immunotherapy today, looking at melanoma mainly, of course, because melanoma is the leader in immunotherapy, as you all know, but looking at other cancers beyond melanoma as well. So you've had some introduction into immunology already, but I want to give you my perspective on what has changed, I think, with immunotherapy. You know that immunotherapy has been around for a very long time. We've used cytokines like IL-2, interferon for many years, but they have not been as effective as some of the new immunotherapies that we have heard about already, anti-PD-1, anti-CTLA-4, very exciting. So what has changed in immunotherapy? And this is the way I explain things. As you'll see from my talk, I try to make things very simple. I teach a lot of students, a lot of fellows, and I try to explain to them what is the simplest way to understand this. And as you all know already, the most important cell in the immune system is the T cell. And for many years, we have been trying to always turn on the T cells. And that has not been a very successful approach. The more successful approach has been to take the brakes off the T cell when it is already turned on. So as you can see from the left side of this picture, turning on the T cells has been with cytokines, vaccines. They have not been so successful in immunotherapy so far. Maybe with the newer treatments it might improve, but what has been much more successful is on the right side of this picture, where the T cells are already turned on, but trying to prevent them from being turned off by using anti-CTLA-4, anti-PD-1, and many other options has, I think, made the difference in immunotherapy. So one of the concepts that everyone keeps talking about is a checkpoint, right? And I want to just very simply explain to you what is a checkpoint. A checkpoint is a brake on the immune system. So you can see from this picture that the immune system starts with the tumor. The antigens are released from the tumor, and that can be done by either spontaneously, radiation therapy. You've heard about some interesting data with radiation combined with immunotherapy because that's a way of releasing antigens. Whatever way the antigen is released, it goes to the dendritic cell. The dendritic cell takes it to the T cell, and the T cell becomes active, and then the T cell comes back and through various mechanisms comes back to the tumor and tries to destroy it. So there are checkpoints at various points on this pathway, at the tumor level, at the T cell level. And the checkpoint inhibitors are brakes on that immune system that work at those checkpoints. So I like to give the analogy of a car. It's a very simple analogy. And when you have your antigen recognition, it is like inserting the key into the ignition. You start the car, you have your molecular interactions, you step on the gas, the car starts to move, but then the brakes come on, and the car will stop. So one of the brakes that we have investigated for a long time is ipilimumab. You are aware of the data with ipilimumab. And in fact, the checkpoint inhibitors, the drugs that take off the brakes from the immune system, I've shown some of them listed here. Ipilimumab was approved for melanoma in 2011. Anti-PD-1s, both pembrolizumab, nivolumab, approved for lung cancer in 2014. And you know that pembrolizumab was approved first for melanoma in the US. And there are many others in development. So let us now move to melanoma and focus on the data with melanoma with the checkpoint inhibitor, starting with anti-CTLA-4. And you already know how anti-CTLA-4 works, but I will just show you another scheme to help you understand. So the first thing is that the cell that is most important in the immune system, as we discussed, is the T cell. What's interesting about the T cell is that it is a cell that is quite lazy. It does not work by itself. It needs a lot of help, okay? And the first step that has to happen is that the antigen from the tumor has to be processed by this antigen-presenting cell, APC, in the bottom of this diagram there, APC, which is such as a dendritic cell, for example. It processes the antigen and presents it to the T cell. It says, here, T cell, please take this antigen and react to it. Still, the T cell will not do it without a second signal, and you can see that with the CD28 and the CD80 interaction, that second signal is very, very important, and without that second signal, the T cell will not activate. So once that second signal takes place, the T cell activates, and the immune system is awake. However, then the brake comes on. And you can see the CTLA-4 now that was inside the cell in the first picture is now on the surface, and it is competing with CD28 for CD80. So that interaction is now between CTLA-4 and CD80. CD28 is left alone. The second signal disappears. The T cell shuts down. So that's the brake. So one way to take the brakes off would be to synthesize an antibody to CTLA-4. So you have anti-CTLA-4. That now pulls away CTLA-4, combines with CTLA-4, and the CD28 and CD80 are once again interacting. Second signal is active. T cell is active one more time, and your immune system is active again. So this is a way of taking the brakes off. As you can imagine, this can be quite powerful, but also leads to the side effects of treatment. And you know that the side effects of ipilimumab are almost all immune-mediated because of this mechanism. So there were two trials. You're familiar with this data with ipilimumab, one in second line. You saw the results already in the previous talk, and first line. Both show improvement in survival, and we don't have to go into detail, but the trial on the left was the one that got the drug approved, 3 milligram per kilogram, once every 3 weeks, 4 doses, improvement in survival compared to a vaccine. This led to approval of ipilimumab. So that was very clear. This was a very important trial for us, the very first time ever in melanoma, metastatic melanoma, that there was a positive survival trial. Never happened before, and this was on the plenary at ASCO. And we never had melanoma on the plenary at ASCO before this trial. So it's a very important study that changed everything for us in melanoma. You saw this already, and this is important because approximately how many patients benefit with ipilimumab? It's about 20 to 25% long-term benefit. So that's good, but it's not great. 75% of people don't benefit, and that's important. We need to find something that's better. And also this drug, as you know, has toxicity, has side effects. So then we come to anti-PD-1. Okay, so you all have seen the science behind anti-PD-1. You know what it does. I'm going to give you my very simple explanation again. I apologize in advance that it's very basic. But the way I like to think about the brake on the immune system is that you have many brakes. Anti-CTLA-4 is one brake. Anti-PD-1 is another brake. So you take off another brake, so what's the big deal? The difference is twofold. One is this brake works not only at the level of the T cell, but also at the level of the tumor. So there's two places that it works. You saw the picture earlier on both sides, okay? So that's important. The second thing is, again, going to the analogy of the car, if you have the car move continuously because you've taken the brakes off, ultimately the car will stop moving because it will run out of gas, correct? So there's the same phenomenon in immunology called T cell exhaustion. So T cells also get tired. So what does anti-PD-1 do? Anti-PD-1 takes off another brake at both levels of the T cell and the immune system, or the tumor cell, but it also fills up the gas tank. It relieves T cell exhaustion. So as you can expect, this is much more likely to be more powerful than anti-CTLA-4. And of course, you have seen the data already. This is better in clinical trials than anti-CTLA-4. But what I find most amazing is that it is not only better, but it is less toxic. And that is amazing to me, because when you look at the mechanisms, obviously we don't understand everything, but why it's less toxic is a bit of a mystery to me. I don't understand that quite well, but it is certainly less toxic than anti-CTLA-4. So you've seen this interaction on both sides, the T cell side and the tumor side, the dendritic cell side. So PD-1 pathway is, of course, very, very important. Okay, so which are the anti-PD-1 antibodies approved by the US FDA? Pembrolizumab, you know this was the first one to get approved in the US for melanoma. It is right now approved in second-line therapy. It is approved after ipilimumab treatment. So currently, we are not able to use pembrolizumab in frontline therapy unless the insurance companies will pay because, as you know, in the US, it's all about reimbursement. They're very expensive drugs. And then nivolumab was approved later in melanoma and also approved in squamous cell carcinoma of the lung, second-line therapy. So, but of course, both these antibodies will soon be approved in lung cancer, and we expect in many other cancers as well. So I'm going to show you the data now systematically, starting with anti-PD-1 efficacy after ipilimumab, because that is the way it got approved first. So we'll start with that, okay? So here you have the data with pembrolizumab presented by Tony Ribas at ASCO a couple of years ago, showing you a few things. One is a high response rate of about 30%, but importantly, in the waterfall plot that you see on the top left corner, many patients, in fact 72% of patients, have some shrinkage of the tumor. Not a RECIST response, but some shrinkage. And that's very important because the very fact that we can show a waterfall plot with immunotherapy is quite amazing to me as well. Who would think we could show that? You know, with IL-2, we have 5% response rates, 10% response rates. The other thing that on this picture you can see is the durability of the response. The response is durable. So durable response, higher response rate, and in terms of post-ipilimumab, this drug looks like it's effective. Then you need a randomized trial, of course. So this was a randomized trial, Keynote 002, for pembrolizumab, looking at 2 different doses of pembrolizumab compared with chemotherapy after ipilimumab. So just to understand, the standard of care in the US became, at least for BRAF wild-type patients, immunotherapy with CTLA-4 antibody, ipilimumab first. After that, if you are BRAF wild-type, you're left with chemotherapy. So this was the trial that was done compared to chemotherapy. There were choices of chemotherapy provided, you can see. And this showed very clearly 2 things. One is that pembrolizumab is better than chemotherapy, but also very importantly, the 2 doses are about the same. And that's important because ultimately the lower dose was picked for further development. You see the hazard ratios and p-values are significant here. And this is the efficacy summary, a little bit hard to read, but essentially higher response rates, as you might expect, with both 2 milligram per kilogram and 10 milligram per kilogram dose. What about nivolumab? Very similar data. This is nivolumab in second line after ipilimumab compared with chemotherapy. Very similar design, except that the pembrolizumab trial allowed the crossover, so PFS was a primary endpoint. This trial did not allow crossover, and this trial showed also higher response rate for nivolumab compared to chemotherapy. So 2 antibodies, anti-PD-1, both showing superiority after ipilimumab compared to chemotherapy. So very clear, no doubt there in terms of its efficacy in that setting. What about moving anti-PD-1 to frontline? Does it work in frontline therapy? Let us start by looking at frontline trial versus chemotherapy. Now, you can understand this trial, there's a BMS trial for nivolumab versus chemotherapy, could not be done in the US because in the US we have approval frontline for ipilimumab, and no one would go on this trial, and this would not be a trial that could be approved in the US. So it was done outside of the US. Chemotherapy versus nivolumab, and not surprisingly, higher response rate and improvement in overall survival, which is very clear-cut. This was a trial that had to be done, unfortunately, but you know, the result was something that was quite obvious. We did not expect that chemotherapy would be better than an anti-PD-1 antibody in frontline therapy. Secondary endpoint, progression-free survival, also positive. So we know for sure that anti-PD-1 antibodies work better than chemotherapy frontline. We know that anti-PD-1 antibodies work better than ipilimumab second line. So what about anti-PD-1 antibodies compared to anti-CTLA-4 antibodies frontline? So you saw this data already a little bit. This is the very important trial that was recently presented at AACR just 3 weeks ago. Pembrolizumab, again, 2 different schedules compared to ipilimumab frontline. This was the study design and disposition. You see that it was a large trial, more than 800 patients randomized into 3 arms. And what did it show? Again, information that's very important. Both doses of pembrolizumab, both schedules, were superior to ipilimumab. So it doesn't matter which schedule that was used. So this is very clear in terms of progression-free survival. We don't have the overall survival data yet. Obviously, it is too early, but the interim analysis is looking very good, that it is going to be a positive overall survival trial when we do the final analysis. I don't think these curves are going to change that much. Response rates also superior to ipilimumab. I think you all know that the response rate with ipilimumab is actually quite low. It's less than 10%. Here is a little bit nicer way to look at the data, again showing you that the Q2 week or the Q3 week schedule of pembrolizumab, now this is 10 milligram per kilogram, so it's a little different compared to ipilimumab, superior results in terms of response rates. These were our conclusions from that presentation: reduction in risk of death, progression-free survival, favorable safety profile. So essentially, it will be very soon that we will see in the US the label for pembrolizumab changed to allow frontline therapy. So based on this trial now, you know, we use NCCN guidelines, you're familiar. Unfortunately, that is not always gives us a chance to use those drugs because insurance companies have to reimburse. So we will see, but many people are now already making preparations to use pembrolizumab frontline therapy. However, it is important to remember that pembrolizumab can work second line as well. So one of the issues that we don't know the answer to is why not give people 4 doses of ipilimumab first? 25% of them will do well, right? They may not need anything more, which is great. 4 doses, you're done. And those who don't respond, you can give the anti-PD-1 second line. Of course, that's make people a little nervous because everybody likes to give their first line therapy to be the best one. So it's going to be a little controversial, but we will see. I expect, however, that anti-PD-1 will replace anti-CTLA-4 in the US very soon. It's already happening, actually. All right. So we talked about individual antibodies. Now let's put them together and see what happens. And you saw some data already. There is a scientific rationale for combining the two. See, in historical treatment of cancer, as you all know very well, we just put drugs together because they were successful as single agents, without any science, any biology. And not surprisingly, most of the time, combination therapies do not work, especially melanoma, they never worked. This is different because there is a good science rationale to put these 2 antibodies together, which has been done in clinical trials. And this was the nivolumab, ipilimumab. There were many cohorts tested in phase 1 and phase 2 trials, and you can see there was an impressive waterfall plot, the bottom line, the bottom one. But very importantly is that there was a high complete response rate. I do want to mention that with anti-CTLA-4 single agent and even anti-PD-1 single agent, our complete response rates are quite low. And that may not be a problem necessarily. I think one of the things that we have learned about the new immunotherapies, the checkpoint inhibitors, is that even without a complete response, you can have a benefit. If you think back to IL-2, if you didn't have a complete response, it was useless. That is not the case with these antibodies. It's a different mechanism. It's a brake on the immune system, and there seems to be a new equilibrium. I have some patients that I have treated with anti-CTLA-4 and now with anti-PD-1 for more than 5 years, sometimes up to 8, 9 years. They still have metastatic melanoma. I can still see it. Every time I get a scan, makes me nervous. Now I'm doing scans every 6 months, and I still see their metastases, but they are not changing there. You go up a little bit, down a little bit. It's a new equilibrium. It's a very interesting phenomenon. But this may change that with the complete response rate. And you are aware of this paper that just came out in the New England Journal of Medicine that we published a couple of weeks ago that is showing that in the randomized phase 2 trial, there was a superiority of combination nivolumab, ipilimumab over ipilimumab alone. This is the design of that trial. Phase 2, not a phase 3. That's important because mostly for approval, FDA requires phase 3 trials. So we'll see what happens with this. But you can see very impressive combination therapy results in terms of response rates, regardless of BRAF status. This is the first time we have good data in terms of BRAF wild type and BRAF mutated patients collected prospectively. And a little bit hard to see, but the toxicity was, as you might expect, higher than with single-agent anti-PD-1, and that's the biggest issue. Though it wasn't as bad as we expected, but there was toxicity. So you have a combination therapy that is better, obviously much more expensive, more toxic. So will that become the new standard of care in the US? It remains to be seen. Issue is going to be of cost, and not everyone is in such a good condition with melanoma to get the combination therapy up front. So I still think there are some unanswered questions in terms of who should get the combination, who should get single-agent CTLA-4, followed by PD-1, or PD-1 first. It's a lot of questions still remain to be answered. So how are we going to answer these questions? Maybe with a biomarker, right? That would be the magic answer, that if we have a biomarker, we will know the answer. Now, the problem is, I will tell you right now, we do not have a biomarker, and unfortunately, I'm quite skeptical. I don't think we will ever have a biomarker for immunotherapy that will be good enough, and let me tell you why. See, the beauty of a biomarker is not so much if it tells you that the response is going to be higher or lower. The biomarker is most useful when it tells you when the response is going to be zero, okay? So when it tells you not to use a treatment, that's when it's most useful. So why is BRAF useful? BRAF is useful not because if you have the BRAF mutation, you must give BRAF therapy. No. It's useful because it tells you if you don't have the BRAF mutation, you must not give BRAF therapy. And that is very helpful because immediately 50% of patients are taken away from that useless treatment that would have done nothing for them. We need the negative biomarker immunotherapy. It will not be there for a long time. I don't think so. There are some exciting data coming out of some gene signatures. You are familiar with this, I'm sure. There seems to be a correlation between what they call mutation load. That means more mutations in a tumor and better response to anti-PD-1. So in lung cancer, for example, smokers do better than non-smokers, which is very interesting. But the data we have available for anti-PD-1 is this data that was presented by Rick Kefford from Australia in ASCO. And in 71% of patients in the pembrolizumab database, they had the PD-L1 staining. And it did look as if you had the PD-L1 staining, there was a higher response rate. So it's there. It's there with this data. It's there with nivolumab as well for progression-free survival. But it is not definitive. In other words, if you have the staining, doesn't mean you will respond. And if you don't have the staining, doesn't mean you will not respond. So how do you pick? It doesn't really help you that much. Maybe it will help if you have 2 or 3 choices and you're deciding which way to go, but it doesn't unfortunately give you the information that we're looking for. So this will take some time. So let's now look beyond melanoma. Quickly, what is happening outside of melanoma? I'm a melanoma doctor. I only treat melanoma patients for the most part. And I'm very fascinated to see that in diseases like urothelial carcinoma, transitional cell carcinoma of the bladder and urinary tract, there are responses in patients with single-agent pembrolizumab after progression on multiple prior chemotherapies. And you see that 64% of patients had some shrinkage. Small numbers, don't consider this to be definitive yet, but it's very, very interesting. And again, the response duration is quite high, which is, again, very, very interesting, I think. Gastric cancer. Who would expect gastric cancer would have a response with immunotherapy? Once again, you have a response rate in gastric cancer that looks interesting with durability. Head and neck cancer. This is HPV negative, HPV positive. It doesn't matter. Once again, you have a benefit seen in some patients, whether they're HPV positive or negative in head and neck cancer. So as you can imagine, there are now randomized trials going on at my center and many other centers looking at these antibodies in all these cancers. So we have 3 head and neck cancer trials open now looking at anti-PD-1, anti-PD-L1. Some of these trials, unlike melanoma, require the patient to be PD-L1 staining positive. Okay, they're trying to enrich the population. So maybe in other solid tumors, maybe the PD-L1 staining will be a good marker. But I think it's mostly because there are so many options in those tumors. You know, you have chemotherapy that works, so you have to find some reason to treat or not to treat. So we're looking at staining. Even in other cancers, it doesn't mean that if you don't have the staining, you won't respond. So it's not yet clear. So let's finally wrap up with clinical implications for practice. So we are in the clinic. How is this going to affect what we do? You've seen this already. So the first thing is you have to be careful about when you decide the treatment is not effective, because there is a phenomenon that we call pseudoprogression, or whatever you want to call it, where initially there could be an increase in the tumor size, and then there may be a decrease afterwards. Now, I do want to put a word of caution here. This is not as common as it looks. You know, we show this slide all the time. It's a very exciting slide. It makes it look like this happens every day. No. This is not as common as it looks. You know, we show this slide all the time. It's a very exciting slide. It makes it look like this happens every day. No. It only happens about 10% of the time. And that's important to remember, okay? So if a patient is having progression and it's obvious progression, don't expect this to happen. But if a patient is feeling well, has a little progression, usually chemotherapy you would stop. With immunotherapy, you should continue. Should consider continuing, especially if they're not having any symptoms. So this is an example of that. It happens with ipilimumab, it happens with pembrolizumab, it happens with all these antibodies, just like you would expect. That if you have initial progression, you can sometimes get later responses. So keep that in mind. You saw this picture already. So one of the issues is, can we modify RECIST criteria to reflect this? So there is something called the immune-related RECIST criteria that are being developed. These are examples. This is a table that's showing this. I will tell you that this is not yet accepted by everyone, okay? Because, you know, we still are stuck with RECIST for now. Maybe one day we'll think about this, but this is difficult to put in a clinical trial, for example. And maybe with the new antibodies like the anti-PD-1s and the combination, this may not matter so much, because I don't think pseudoprogression is so important when the drug is so effective. It may not be that important. However, in data so far, if you split up the responses by RECIST response on the top, RECIST and immune progression at the bottom, and in the middle you have RECIST progression but immune response, there is a difference in survival. So it does correlate with benefit. In other words, if you have a patient that's progressing by RECIST but responding by the immune-related criteria, you could have a benefit there. So that is a good reason, in the clinic at least, to keep that in your mind and use that to decide whether or not to stop treatment. It does help you in the clinic, not yet in clinical trials. Okay, toxicity, another issue. You all know this very well. Ipilimumab toxicities have been very scary for a long time, especially when the drug was new. We did not know how to monitor these, how to manage these, and there were some very bad outcomes. And this gave the drug a bad name for a while, until we learned that, you know, there are steroids you can use, and so you know about skin rashes, hypophysitis, diarrhea. Approximately 30 to 40% of patients have toxicity with ipilimumab, okay? But the issue is not so much the toxicity. The issue is, when does that toxicity happen? See, when you give IL-2, you give the patient IL-2 today, they get toxicity today. If you give interferon today, they get toxicity tonight. With these drugs, ipilimumab, pembrolizumab, nivolumab, the toxicity happens later. It happens when the patient is at home. And that is very important. There's a time frame for this. The rash is the first thing, liver comes later, diarrhea somewhere in the middle, endocrine toxicity at the very end, and it can happen even after you stop treatment. So you need the patient to communicate with you very clearly. That is the most important thing we have learned, is our patient communication. So I know in Mexico, you know, you have the doctors take care of the patients, the nurses are involved. We have a huge nursing involvement in the U.S. So we have our nurses communicate with the patient at least once a week on the phone. We instruct them in writing. They must call us. They have one diarrhea episode, they must let us know. Just to let us know, so we are able to be aware that they might be having a side effect, and we can communicate with them more often. So that's important. And as you all are aware, there are very nice tables and algorithms that are established for IPI, and we can use them with some modifications for Pembro and Nivo, but they are designed to intervene at the right time with steroids to make sure that the side effect is picked up early and treated early. The difference between treating the side effect early and late is huge. It can be someone who just has a treatment at home versus going in the hospital. It's that important. And you all know this very well. The wonderful news is, I've told you already, that with the anti-PD-1 antibodies, and this is data from KEYNOTE-001, the pembrolizumab, and it's very similar for nivolumab, the toxicity is much less. Single-digit toxicity. It is not as much as what it was looking like with ipilimumab. So that's good news for patients. These are the immune-related side effects from KEYNOTE-001. Once again, you look at grade 3 and 4, all single-digit toxicities. Not a very common thing to happen, though you must be careful and look for them. So let me end by coming back to melanoma, because now we have an algorithm that we consider to be, outside of a clinical trial, a fairly straightforward approach to understanding and treating melanoma. But this is evolving. It is changing. The standard of care is changing so fast, it's hard to keep up. So the first thing you diagnose melanoma, you do the BRAF mutation test. I think that's very clear. Every patient should receive this because it gives you information that is very critical. Now, as I said earlier, the definitive answer, if you're negative for BRAF, you know not to use the BRAF therapies. So right now, the standard of care is anti-CTLA-4, followed by anti-PD-1, followed by chemotherapy, if we have nothing else left. This will probably change, as we talked about. Maybe anti-PD-1 will come on top. Maybe combo will come on top. I don't know. If you are BRAF mutation test positive, then certainly you have the option to give BRAF and MEK combo therapy. We don't use single agent BRAF. Is combination approved in Mexico? BRAF MEK combo? No. So we use combo because the data is better, but many countries have single agent, vemurafenib, until we get the combo. So that is an option, but also you have the option of others, anti-CTLA-4, anti-PD-1, now of course combinations. And I think that now, because of the good data with anti-PD-1 and anti-PD-1, anti-CTLA-4 combination therapy, that more and more patients with BRAF positive melanoma will receive immunotherapy first. So right now, among BRAF positive patients, what has been the trend in the US, and we don't have very good data, but it seems to appear that about 30% of patients are getting immunotherapy first, 70% are getting BRAF therapy first, if they're BRAF mutated. I think that's going to switch completely opposite. I think it's going to become 70% will get immunotherapy first, and 30% will get targeted therapy first, for many reasons, because immunotherapy may be more durable, we know that, though of course BRAF therapy may be durable as well. But the most important thing is that BRAF therapy, if it works very fast. So even if the immunotherapy does not work initially, most of the time, you have some time to give the patient the BRAF drugs and get a response. The other way around is much more difficult. So I will end here. Thank you for your attention, and I'll be happy to take any questions you might have. Muchas gracias. Are we taking questions, or yes, no?
To use in first line without any data prospectively confirm about it.
So actually, the one slide I showed you of the data with ipilimumab, there was a trial that was done frontline. However, it was a different dose. It was 10 milligram per kilogram. Yes, correct. But it was compared with chemotherapy up front. So it is a bit of a, as we say, a leap of faith. Okay, but in the U.S., the FDA took the assumption that this was the first major breakthrough for melanoma immunotherapy, and given that there was data in frontline, different dose, agreed, even though the second line trial was the one that was 3 milligram per kilogram, they gave it full approval in all lines of therapy. That is controversial. Mexico, Brazil has the same thing. I think some European countries have the same requirement that they need to progress on chemotherapy first. However, I feel that, in my opinion, chemotherapy for melanoma should not be used frontline anymore for anybody, unless they cannot receive the drugs or they are not candidates for some other reason. Because we have so much data now that immunotherapy, whether it's anti-PD-1, you saw the anti-PD-1 at least for sure, is better than chemotherapy up frontline. That, to me, it would be a mistake if the patient has access to it to give them chemotherapy first, in my opinion. Now, you know, it's a complex problem because these are very expensive drugs, and different countries have to look at it in a different way. As you know, in Europe, approval is one thing, reimbursement is another thing. You know, in the U.S., fortunately, or I don't know whether it's fortunate or not fortunate, but approval equals they will pay. That's the difference. So if FDA in the U.S. approves a drug, insurance companies are obliged to pay for the drug. FDA does not regulate price, unlike in Europe where they regulate price as well. Maybe they should regulate price in the U.S. too, because it's so expensive. And I am very concerned about combination therapies, for example. They will go front line, right? because the combination is better than Nivo and Ipi, but theoretically, no one has proved combination is better than chemo, even though single is better than chemo. So you're making a lot of assumptions, but that's what you have to do. So we don't use chemo frontline for melanoma at all anymore. Hector?
Do you have some information about adjuvant therapy with this kind of therapy, immunological?
Yes. So thank you, Hector. We have the data, as you are aware, EORTC trial of ipilimumab versus placebo at 10 milligram per kilogram dose, so it's a higher dose, with a positive relapse-free survival for melanoma patients, high risk, stage 3, compared to interferon as well. I mean, you know, that data is going to come out soon, I would think. So right now, theoretically, with a 10 milligram per kilogram dose superiority to placebo, not yet, no data with interferon yet, there is a potential to use it adjuvantly in the US. However, I don't think anyone is doing that because it's the 10 milligram per kilogram dose, and the 3 milligram per kilogram dose data is not available yet. So for someone to just assume that 3 milligram is as good as 10 and to treat patients would be incorrect. And you cannot give 10 because you would be giving so much IPI that it would be too expensive. It cost, the calculation is $1 million per year. It will be the cost of IPI at 10 mg per kilogram for adjuvant therapy. So in my opinion, right now, we should stay with interferon until we know more. There is an important trial, ECOG, that is completed of AP3, AP10 versus high-dose interferon. That data will take another, I think, at least 2 years. And then there is a new trial that has started of nivolumab versus ipilimumab. So Bristol Myers has taken the assumption that 10 milligram per kilogram is the right dose of IPI for adjuvant. And their trial is nivolumab versus ipilimumab at 10 milligram per kilogram. And I know that Merck is planning a pembrolizumab adjuvant trial as well that will start soon. So until we know more, I don't know that we can use these treatments in adjuvant therapy yet. Yes?
Thank you. Thank you for your talk. In the past, as a treatment for melanoma, we're using activating anti-CD40, I mean, CD40 and CD28 with significant advance.
Yeah.
What about that?
Yeah, so, you know,
compared with this?
Yeah, we don't have comparison data, right? Yeah. I think those are, I would just say this, that there are so many possibilities, very exciting antibodies. Anti-CD40 is one of them, make a lot of sense. And they have good data in phase 1. They may go to phase 2. The big concern is that, you know, with the data now with anti-PD-1 and combo anti-PD-1, anti-CTLA-4, for those antibodies to move forward is going to be very, very difficult because if FDA, whether it's US or Mexico or wherever, is going to require randomized trials, you're going to have to randomize hundreds, maybe thousands of patients because one would expect that those exciting antibodies will not be 100% effective. They may be 60%. And if combo is 40%, to go from 40 to 60, you need many more patients than to go from 10 to 40. So that is the concern. And I think what is going to happen for those antibodies, even anti-PD-L1 antibodies, as you can see already it's happening, they're doing the trials not in melanoma but in other cancers because there are many more patients. The market is bigger, you know, of course, right? Melanoma is a small disease. We have in the US 9,500 stage 4 melanomas per year. That's the market. 50% are BRAF wild type, so you cut the pie halfway. And then you got IPI, Nivo, Pembro, combo, clinical trials. Yeah. It's going to be crazy. Yeah. How do you do that, right? How do you do these trials? It's impossible. No. So one of the important trials, we did not talk about targeted therapy, but very important trial. I don't know if it's important, but let me tell you the trial. I just came back from ECOG, you know, the meeting, right? Yeah. And there's a trial that is in development for now 2 years, and finally the design is settled. Because the question of the trial was, for BRAF positive patients, should we give them immunotherapy first or targeted therapy first? We don't know. We just assume. So a randomized trial. So the trial took a long time because the immunotherapy arm was controversial. Should it be IPI? Should it be PD-1? Now it's decided to be combo. So this is the trial where patients with BRAF-positive melanoma will be randomized to receive BRAF-MEK combo or IPI-NIVO combo with crossover. So now that's a trial that will be done by the cooperative group. It's going to take a long time anyway, and it will answer a question that I think we already know the answer to.
No, it is not.
Yeah, right? I mean, the point is that, like, you know, you just, there are only so many trials you can do, so where do you factor in these new antibodies? It's going to be very, very hard to do. I think it's going to be it's a depressing thing. It's a problem, a good problem, but a problem.
Okay, thank you for it.
Thank you. Yes. Yes.
Talking about the biomarker, do you think that it's possible that maybe in those patients that we have a response but a low but very low expression of PD-L1, it's maybe a problem of measure because
yes, sure.
It's maybe alternative spacing or something like that?
Yep. Yeah, no question. Thank you for that question because that is exactly right. I showed a slide with 1% cutoff, 5% cutoff, so it depends on what cutoff you use, what method you use. The BMS trials and the Merck trials use totally different measurement systems for PD-L1 staining. People say the Merck one is better. Who knows? I think that's part of the problem, right? So I think that with immunotherapy, it may be a composite of different biomarkers. Maybe PD-L1 staining is one thing. Maybe it's the gene signature up front is another thing. Maybe you give 2 cycles of therapy and you measure T-cell subsets, Tregs and T helpers, and come up with formula. And then maybe you have all that together in a table, and then use an algorithm to say you should continue the immunotherapy or not. But it is definitely a marker of the testing, for sure. You know, with BRAF also, until it was standardized by COBAS testing, every lab did it their own way. So you can still have a BRAF test that's positive in one lab, negative in another lab. You can imagine PD-L1 is even worse.
Sorry, in your clinical experience, do you use the biomarker for the treatment decision? Or?
No, not at all. Not yet. Not yet. The only biomarker we're using is our head, you know, right now, literally. You look at the patient, you decide if the disease is a high-tempo disease or low-volume disease, to decide between immunotherapy and BRAF for BRAF-positive patients. Does a patient have time to react to the immunotherapy? There's not a good biomarker yet. In fact, in no melanoma trial is PD-L1 staining required for accrual, as you know. It is required in other solid tumors. In melanoma trials, it's only being collected as data to understand later on. Thank you. Now Hector and I can go to Oaxaca. Mexico.